I think that three things that we need to look at with traumatic brain, or several things we need to look at with traumatic brain injury. One is we're seeing this a lot, and it's a huge amount of mortality with traumatic brain injuries. And when you look at traumatic brain injuries, we talk about the primary injury and the secondary injury. The primary injury is the injury that happens right at the time of the impact. They hit their head on the ground, they fall, they hit the head on, cement, they're in a car accident, they hit their head on the windshield, whatever. That's the primary injury. There's nothing we can do about that other than injury prevention, programs. But the secondary injury is the injury that occurs after that, and that's where we come in effect. They talk about the 3 H's of traumatic brain injuries, and one is hypotension, a single blood pressure less than 90 systolic on a hypotension on a traumatic brain injury, at least doubles your mortality. Then hypoxia. A single SAT less than 90% at least doubles your mortality. And the third thing was hyperventilation. And used to, for all of us that have been doing this for a while, we used to hyperventilate all of these traumatic brain injuries. And we found that is the worst thing to do. So even mild hyperventilation at least doubles your mortality. And you say, well, why is hyperventilation bad? Well, hyperventilation, decreasing the PCO2, actually causes vasoconstriction to the brain, to the blood flow to the brain, which decreases blood flow to the good brain that's left. It's not going to affect probably the brain's already damaged, but you're affecting the good brain. So 3 things. Don't ever let them get hypotensive, so you need to give them IV fluid. So that's the reason I said a while ago that permissive hypotension certainly is something that we would not even entertain in a traumatic brain injury. You want these people to get fluids. You never want them to get a blood pressure less than 90. High flow O2. Even somebody that's just a mild head injury, put them on non-rebreather mask. You do not want these people to get hypoxic. And then hyperventilation. Now, I'm not talking about them hyperventilating. I'm talking about active hyperventilation by us. And when you look at the hyperventilation, it's real important that we use, if we intubate. Now, there's a lot of controversy about pre-hospital intubation in traumatic brain injuries, especially with RSI. And there's some studies and some people that say you should never RSI a traumatic brain injury in the field if you can manage their airway with a bag valve mask. Yes, intubation is much easier ventilation, but what it does is it increases the chance of you hyperventilating the patient. There were some studies that said very common for an intubated patient in the field, traumatic brain injury patient, to be bagged at 24 to 40 breaths per minute. And we really should shoot for greater than 14, basically an adult, 10 breaths a minute. That's what we should shoot for. That's hard to do. That's hard to change that mindset. But these people that are greater than 14 years old, we really don't want to breathe but 10 times a minute for these people that are intubated, or if we're bagging them with a bag valve mask. 2 to 14, about 20 breaths per minute, and 0 to 2, only 25 breaths per minute. So we really look at the EndTidal CO2, and that is something that we truly need to use in traumatic brain injuries. We should shoot for that EndTidal of 36 to 40, 42, 43. There's a general rule around 40. We don't want to get it down to 25 because you're causing that vasoconstriction. You're going to cause increasing secondary injury. Now, mild hyperventilation, some people will use that term, and that is trying to get that EndTidal CO2 down to about 30 or 35. Now, that does have a place sometimes just for a brief period. If somebody is really deteriorating, they're blowing their pupil, they're starting to get a decerebrate or extensor posturing or no movement at all, or GCS decreasing by 2 points, those people are impending herniation, and at that point in time, a brief period of hyperventilation, just enough to blow that or to try to reduce that cerebral edema, may help. The jury's sort of out on that, but it may help with that. It's funny because all of us have a difficult time in the field, or most of us, figuring GCS. We're in a hurry. We don't commit it to memory. We commit it to memory for the test, and then as soon as the test is over, we some of us have a card in our pocket or whatever. But it's really important that I don't expect you to commit it to memory, but have a card, because especially on a long transport time, if you're starting to see a GCS that decreases by 2 points across the board, not just motor response, eye response, whatever, but just across the board, that means an impending herniation, which is obviously bad. So GCS, EndTidal CO2, real important that we monitor that. We talked about intubation a little bit, but we used to say, well, less than 8 you intubate. But again, there have been several studies, one in San Diego, one in Los Angeles. Los Angeles was a pediatric study that really said there was really no difference in survivability with intubated patients than patients just managed with a back valve mass. And then the San Diego study basically said that intubated patients really probably had more bad outcomes than a patient that was just managed with a back valve mass. So if you can manage them with a back valve mass, watching the EndTidal CO2, paying attention to how many breaths they're getting, 10 breaths, watching the EndTidal CO2, then you're gonna give your patient a much better chance of survival and meaningful recovery than if we just hyperventilate these people. So high flow O2 on every head injury. IV fluids, if you need to bolus with fluids, don't ever let that blood pressure get below 90, and then don't ever hyperventilate those patients.